Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a pharmacist, and I like to talk about medications. And if you'd like to learn about medications, then I think this is the right channel for you. Today's video is titled Other Antihypertensive Medications, so I'll just go ahead and get started. I like to start off my videos with just a couple of questions just for fun. Question number one, Aliskiren brand name Tecturna lowers blood pressure by which mechanism? A. Blocking angiotensin II at the angiotensin I receptor. B. Inhibiting ACE-mediated conversion of angiotensin I to angiotensin II. C. Directly inhibiting renin and reducing conversion of angiotensinogen to angiotensin I. Or D. Blocking aldosterone at the mineralocorticoid receptor. Question number two. Which safety concern applies to endothelin receptor antagonists such as aprocitentan? A. Embryo-fetal toxicity. B. Tendon rupture. C. Severe hypoglycemia. Or D. Irreversible ototoxicity. Last question, question number three. Which monitoring plan is most appropriate for a patient started on baxdrostat? A. Monitor potassium, sodium, and renal function. B. Monitor uric acid and hearing function only. C. Monitor heart rate and PR interval only. Or D. Monitor INR weekly. The first medication I'll talk about today is Aliskiren, which is a direct renin inhibitor approved for hypertension. Its brand name is Tecturna, which is what I'll refer to it as. It works by inhibiting renin, the enzyme responsible for the conversion of angiotensinogen to angiotensin I, which reduces downstream angiotensin II and aldosterone effects. Tecturna is not considered a first-line antihypertensive agent because it lacks cardiovascular outcomes data, demonstrating reductions in morbidity and mortality. Tecturna is contraindicated in patients with diabetes taking either an ACE inhibitor or an ARB based on data from the Altitude trial. This trial was designed to determine if adding a direct renin inhibitor to an ACE inhibitor or ARB would lower cardiovascular and kidney complications in patients with type 2 diabetes. The trial was stopped early due to increased rates of renal dysfunction, hyperkalemia, hypotension, and a trend in higher risk of non-fatal stroke. Adding Tecturna also failed to reduce cardiovascular deaths, stroke, MIs, and advanced kidney failure. Many of Tecturna's contraindications and warnings overlap with other RAS blockers. It has a box warning for fetal toxicity and can also cause angioedema, acute renal failure, and hyperkalemia. In clinical trials, 150 milligrams to 300 milligrams per day as monotherapy provided blood pressure reductions comparable to hydrochlorothiazide, valsartan, lisinopril, and other RAS inhibitors. It has a low oral bioavailability of around 2.6% and should be taken with a consistent meal pattern because high-fat meals significantly decrease absorption. Overall, because of its lack of cardiovascular outcome data, it should be reserved for patients who are intolerant to preferred first-line antihypertensive options. Aprocitentan, brand name Trivial, is a dual endothelin receptor antagonist approved in 2024 for the treatment of hypertension in adults who are not adequately controlled on other antihypertensive medications. Trivial works by inhibiting the binding of endothelin 1 to both endothelin A and endothelin B receptors. Endothelin 1 is a vasoconstrictor peptide primarily produced by vascular endothelial cells. Endothelin 1 contributes to vasoconstriction, vascular remodeling, inflammation, sympathetic activation, and increased aldosterone synthesis. By blocking this pathway, Trivial provides a complementary mechanism of blood pressure reduction that does not directly target the RAS or sympathetic nervous system. I think it's important to discuss why it's only approved for add-on therapy in patients with resistant hypertension. The Precision trial enrolled patients with a systolic blood pressure of 140 or higher, despite optimized triple therapy, including a diuretic. It was never tested as a standalone first-line agent in phase 3. Endothelin receptor antagonists as a class cause fluid retention, peripheral edema, and hemodilution, which is a significant limitation for standalone use. In the Precision trial, Edema and fluid retention occurred in 9% of patients on the 12.5 milligram strength and 18% on the 25 milligram strength versus 2% with placebo. The mechanism involves endothelin B receptor mediated increases in vascular permeability, venal dilation, which increases venous capacitance, leading to fluid redistribution and retention. The use of a diuretic in the trials helped mitigate this effect, but if we were to remove the diuretic, this adverse effect would likely be much higher. There are no controlled trials demonstrated that TRYVIO reduces cardiovascular events such as MI, stroke, or death. In addition to fluid retention, the endothelin receptor antagonist class carries risks for hepatotoxicity, anemia, and teratogenicity. When added to an optimized triple antihypertensive therapy, TRYVIO can be expected to produce a placebo-corrected office systolic blood pressure reduction of about 3.8 millimeters at 4 weeks. This may seem modest, but we have to take into account that this is a population that is already optimized on 3 antihypertensives and still uncontrolled. At the population level, even small sustained reductions in systolic blood pressure are associated with meaningful reductions in cardiovascular risk. The 2025 AHA-ACC hypertension guidelines position TRYVIO as an option for patients with resistant hypertension who are intolerant or have contraindications to mineralocorticoid receptor antagonists. Baxdrostat, brand name Baxfendy, is a first-in-class selective aldosterone synthase inhibitor approved by the FDA in May 2026. It's indicated for the treatment of hypertension in combination with other antihypertensive medications in adults that are not controlled on other medications. Baxdrostat selectively inhibits CYP11B2, commonly referred to as aldosterone synthase, which is the enzyme responsible for the final 3 steps of aldosterone biosynthesis in the adrenal zona glomerulosa. Decreased aldosterone synthesis leads to decreased sodium and water retention, vascular dysfunction, inflammation, and fibrosis. It has a higher selectivity for CYP11B2 compared to 11-beta hydroxylase, which is a closely related enzyme involved in cortisol synthesis. In clinical trials, it reduced plasma aldosterone concentrations by up to 70 to 83% without affecting cortisol responses or synthesis of sex hormones such as testosterone or estrogen. In the phase 3 BaxHTN trial, 796 patients with uncontrolled hypertension or resistant hypertension with systolic blood pressures between 140 to 170 were randomized to Baxdrostat 1 mg, 2 mg, or placebo once daily for 12 weeks, followed by an open label and randomized withdrawal phases. At week 12, Baxdrostat significantly reduced office systolic blood pressure compared to placebo. The placebo-corrected systolic blood pressure reduction was 8.7 millimeters with the 1 milligram strength and 9.8 millimeters with the 2 milligram strength. During the randomized withdrawal phase, patients switched from the 2 milligram strength to placebo experienced an increase of 5.1 millimeters versus those who stayed on Baxdrostat, confirming its sustained efficacy. There are several phase 3 trials underway to assess whether Baxdrostat's blood pressure lowering translates into hard cardiovascular and renal outcomes. Baxdrostat's main safety concerns are electrolyte disturbances. The most clinically significant adverse effect is hyperkalemia. Potassium should be monitored prior to initiation and during treatment. Sodium should be monitored as well. During clinical trials, hyponatremia occurred in 19 to 23% of patients versus 7% with placebo. Baxdrostat can also cause a decrease in eGFR. In clinical trials, the average placebo-corrected eGFR decrease at week 12 was approximately 7 to 8 millimeters per minute, which appeared to stabilize and was partially reversible upon withdrawal, which may reflect a hemodynamic effect rather than structural kidney damage. The recommended dose is 2 milligrams by mouth once a day with or without food. For patients at risk of hyperkalemia or hyponatremia, the recommended dose is 1 milligram orally once a day. The answers to the questions are 1 Charlie, 2 Alpha, and 3 Alpha. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and leaving me some feedback. Thank you. Have a great day.